And obviously to be able to do that, we need to know that's often overlooked in terms of demographics in Ireland, which is simply the size of our population and the fact that we've had really strong population growth and consistently strong population growth. So at the moment our population is just over 5 million. If you go back to 1960, it was less than 3 million, and that really internationally, that's quite exceptional. So you have to think, I suppose, about the growth rate of the population, but then also the composition. And we all know that the population is getting older. So at the moment, we've got about 15% of the population over the age of 65. In 10 years' time, that's going to be about 20%. And that sort of pace of increase is increasing all the time. But I suppose one aspect that has really sort of come out of our research in terms of projecting what that means then in terms of the use of services, and then obviously for the public purse in terms of expenditure on those services, is that if you look between men and women, there's a really interesting pattern in terms of utilisation and substitution. What seems to be happening is that when men get sick, women are much more likely to enter long-term residential care when they get very sick or infirm, whereas men have a spouse at home generally to look after them. So there's that really interesting substitution, and we think that that is obviously going to be a major sort of policy issue going forward. So I think people have spoke a little about sort of the caring responsibilities. Another thing I think that's interesting as well, and I think Rona mentioned this as well in terms of the labour market, is you see this phenomenon as well of the sandwich generation. So this is where women, they have potentially, teenage children, but they also have living parents as well, and they're sandwiched between the two, and they're also trying to work. And that's a phenomenon that you see sort of coming through in the Irish context at the moment, just by virtue, I suppose, of the fact that we have increasing longevity, so our parents are. I suppose in terms of the sort of only here, so you'll see that actually our projections show that we expect that actually there'll be a reduction in demand for maternity services, for the next 10 years or so. The expenditure won't decrease by as much, and I think that's possibly due to the sort of increasing complexity of cases and sort of risk factors for sort of more expensive deliveries. But that's really a sort of a focus and a sort of a consequence of the fact that we had really strong sort of population growth in the 70s and 80s. So my generation, part of the sort of baby boom, we then had children, in the sort of early part of the 21st century, but that's really starting to fall off. So you'll see that sort of reflected in projections then around maternity care. So I think there's sort of interesting dynamics in terms of the use and also the expenditure on different types of health services as you go through these sort of demographic projections. Just, I suppose, as a final note in terms of demographic projections, they're really difficult to do, and we've often been wrong. It's reasonably okay in terms of projecting births and deaths. We can do a reasonably good job of that. But in Ireland, what really determines sort of the ebbs and flows in terms of the population is migration. And I know, Mary Bridget, you mentioned sort of ethnic identifiers and ethnic inequalities more generally. But really one thing that determines our sort of size of our population and the growth of our population is these sort of net migration flows. And I think an earlier panellist mentioned, 17% of the population were not born in Ireland. And that obviously leads to, particular issues in terms of sort of access to healthcare. Mary Bridget mentioned it in the context of travellers and sort of navigating a health system that might not be sort of designed for your particular needs. And we've also shown this at the SRI. There's some evidence in relation to, for example, use of healthcare services like GPs and consultants among people who are not born in Ireland, that even when you take into account, insurance or their health status, they still have lower levels of use of healthcare. So, there's something else going on there, and it's obviously, potentially due to sort of difficulties in communication in navigating a health system that they're not familiar with. So I'll leave it there in terms of the broad patterns.
Just to find it so important, reduce life expectancy.
Yeah,
This whether we're looking at morbidity, whether we're looking at outcomes. We saw this in COVID. Time and time again, we see actual harm, morbidity, mortality arising within ethnic groups, and I think that is a real key area across the system, and not just for women, but for men too, actually, but across the system that we do need to engage with.
I would like to get some reaction from the Minister. Minister, what I'm hearing from all the women on the panel here this afternoon is two things. One is, it seems to me that there is an expectation, and women are being sort of groomed societally to be society's carers, and who cares for the carers, but also that there are significant barriers for women in particular, and that is an exaggerated version of that for women from a minority group, accessing healthcare in the first place. So we have twofold. We have like the little red hens of society running around, not being listened to, not being looked after, and significant real barriers that are resulting in adverse outcomes for women in accessing healthcare. What are you going to do about it?
It's been clear to me women with the healthcare they need. I've seen it in my own family. I've seen it with my female friends. You know, I over many years had conversations with female friends of mine who were presenting a bit like your story, Ciara. You know, they were presenting sometimes, let's say, with a serious hip issue, and we're just told, "Ah, well, you know, that'll be due to the child you gave birth to 3 years ago, and you know, don't be worrying your head about this." This very patriarchal, very patronising culture, but also services that aren't designed around women, services that have been designed around the healthcare system and around the state. And as we know, it has always been a patriarchal state, right? And so I was determined to be part of changing that, right? So what I said when I was appointed to office a little under 2 years ago was that in terms of clinical strategies, we have many excellent clinical strategies. The problem is they weren't being funded. So I said, okay, we're going to fund them. We're going to fund the cancer strategy, the maternity, dementia, trauma, etc. We're going to fund all of those, but we're missing a women's health strategy. And so the conversation we had politically, the conversation we had in government, the conversation I had in the department was, I'm not interested in a 5 or 10, I'm not interested in a sort of a 3-year intellectual exercise as to how things might get better in the future. I want an action plan, and it must be radical, right? We're not looking for things to get a little bit better each year for the next 20 years. We need radical change, we need radical improvements. And we need it in 2 areas, and they've been covered really well here today. In services, we need services designed around women. We need radical improvements in them. But we also need to change the experience of healthcare. So before I ran for the Dáil, I was working in the NHS and working around cultures within healthcare systems. And a lot of it there were a lot of issues being raised in the NHS at the time. And so what we did was we had this incredible group, the Women's Health Task Force. They spent about a year listening. They went all around the country, listened to clinicians, service users, advocacy groups, and what they brought back made for very sobering hearing. It was page after page after page of the doctor who hasn't got the training. So there was a huge piece of work was done there, and there's a really strong team within the department and the HSE, and they've had the great benefit of being able to reach out to many of the people, you know, the kinds of people who've been speaking here today. So the second thing then we needed to do was find the money. So to give you a sense of where we're going in terms of the funding, in 2020 there was €4 million ring-fenced for women's health. Now, there was more money, obviously there were other things going on, but there was €4 million. This year it'll be €40 million, right? So we'll have gone up by a factor of 10, and the full year amount for this year's services is actually €50 million. So we'll have gone from 4 million to 50 million in a year and a half, right? Because without the money, it's just talk, right? As anyone working in healthcare using the system, without the cash, it's all just good intentions, right? So what we're doing is we're saying, what we need is we're building out a national network of service provision. And at the site as the GP lead for primary care, we're investing. Now, 12 months ago we had none, right? So we'll have a national network of 20. They're incredible, right? So the one in the Rotunda which I was in about 6 months ago, in its first 3 months of operation, reduced its long waiter list by 90%, 90%. The one in Galway was beginning to see similar results. There's one in the NMH, 20 of them. So 8, we opened 8 last year, we're opening the other 12 this year. We're opening 6 regional fertility hubs. We've specialist menopause clinics, specialist endometriosis clinics, eating disorder teams. And what we've been working on is designing all of this around women and life stages. Because for men, it's more linear. You know, there's this massive turn at puberty, and then it kind of steadily gets better and steadily gets worse, and then something bad happens to you broadly. It's not that, but of course, it's much more complex in terms of life stages for women. So we wanted to make sure we were looking at and asking and listening about all of those life stages.
Minister, do you think we need a Minister for Women's Health?
Well, I'd like to think we have a Minister for Women's Health.
That's fair.
Right?
That's a fair response.
I would like to think we do. I mean, in terms of
so you see yourself as a Minister for Women's Health?
Yeah. I mean, the top priorities have been COVID, waiting lists, universal health care, women's health. Okay. Right? We have put it at that level. It's getting that level of attention. Now, do I think there's an argument in the future for a Minister of State for when we've got mental health, we've got older people, we've got disability for women's health? Yeah, I think there is a lot of merit to that, because what a Minister for State brings is daily interrogation and pressure and advocacy, okay. Right? Because I've got many different things that I'm pushing on, but if you have a Minister for State every single day, they're out in the system making sure that these things are happening, listening, okay. bringing that information back, and then working with the HSE and the healthcare community to make sure that what we've promised actually happens.
Can I ask you, because you mentioned one of the key things that you want is delivering to women the healthcare that they need and are entitled to, which brings up the question of the National Maternity Hospital. The National Maternity Hospital is due to be opened, and I know, Rona, you have advocated for it for a very long time, and I trained in Holles Street too. I know how difficult it is to work in that environment. But there are concerns, and they are ongoing, which is why there are protesters outside and why that conversation continues. One of the issues is the fear that women will not be able to access the health care that they are entitled to in the setting that it is due to be delivered. And when you think about it as a hospital, the National Maternity Hospital is the sort of at the forefront of delivering women's health care. And the new constitution that is being drawn up says that women will be entitled to health care that is clinically indicated and legally permissible. But that term, clinically indicated, if you are 10 weeks pregnant and choose to terminate, there may not be a clinical indication. And there is a fear that some people have said publicly, many public figures, and indeed legal minds have said that that term specifically is open to interpretation, and that it is potentially going to be the case that women who are sub 12 weeks pregnancy, who would choose to terminate a pregnancy, that their autonomy will be eroded by the term. Why is it there? And what will it mean for people? Because it's no good in 5 years' time if the thing is built and suddenly we find, oh, we made a mistake, the Catholic ethos does affect women's health care. So how are you going to reassure people? Because this is rumbling on and on and on, and I might come to you about it as well. I'm going to attend the National Maternity Hospital.
Investment we're going to make in women's health care for a very long time. The Holles Street is not fit for purpose. We all know that, right? I was there again recently. I was there as a new dad. I was there again recently. It's not fit for purpose. I think everyone accepts that. And I think we are all on the same page in what it is we want to achieve, right? What we want is a world-class hospital. We want it right beside a big adult hospital. That's national policy, and it's really important for continuity of care for women. We all want that. And we all want, at least everyone I speak to, and I would imagine everyone here, but who knows, most people, I certainly want, and the government policy is that all services will be available, just like they are in Holles Street.
Sure. Right?
Absolutely. So that's what everybody wants, right? And in an ideal world, we would own the land, right? And it might be a HSE run hospital. Holles Street isn't. You know, they're not. It's a voluntary hospital. The NMH is a voluntary hospital.
Run by a group that has a Catholic ethos. The St. Vincent's Hospital group, you know, subscribes to the ethos of Mary Aiken and all of that.
No, I'm talking about the NMH.
No, sorry, but but the NMH is going to be a subsidiary of the St. Vincent's Hospital group. A lot of people are concerned that that is a mistake.
Yeah, but it's not going to be, right? The independence. I've never heard anyone criticise the current National Maternity Hospital.
No.
Or suggest it is somehow compromised.
No.
Right? So that level of clinical independence, of financial independence, is sacrosanct, right? So the question is, what is the best solution to this, right? If there were no constraints, we might take the NMH and shift it a few hundred metres down the road, which is what we're doing. People have said, well, we want to own the building, so we do, and we want to ensure clinical independence, which we are through the governance structures. And some people have, as you quite rightly say, Ciara, are asking very genuine questions, saying, well, does the fact that we won't own the land, could that in some way influence things? And the answer is no. I mean, the state doesn't own the land under Holles Street. In fact, it doesn't own the building either. We'll own the building, we won't own the land. And what's been done over the last several years is that the NMH and St. Vincent's and the HSE have been meeting to put a very detailed governance structure in place with one core goal for most people involved in this conversation, which is to ensure the clinical independence of the National Maternity Hospital. I've said many, many times that I will only bring a proposal to government when I am absolutely satisfied that that is the case. And I can assure you government would only sign off on an agreement where that is the case. Now, some people in teasing this out have said, well, you know, maybe the land should be CPO'd, right? Now, in terms of clinical governance, it wouldn't make any difference, right? That's to do with the governance arrangements. But if we were to try and CPO the land, the legal advice I have is, well, first of all, you may not succeed, because the court may well say, but you don't need to own the land. You already have access to the land. You have a lease for several hundred years. So there's no need for us to infringe on anyone else's rights here. Secondly, it may well be the case that St. Vincent's would say, we don't really want to get into a partnership that is starting off in this way. You know, remember, this is a partnership between an adult teaching hospital and the National Maternity Hospital. Wouldn't be a very good way to start off a relationship by sort of parking your legal tanks on the lawn and saying this is what we're doing. So people have said, okay, well, maybe we should go to another place. Maybe we should locate it, let's say, at Connolly or somebody else. There's two big risks with that. One is Connolly is not a Model 4 adult teaching hospital. It's a much smaller hospital. And secondly, we'd probably add 10 years to the project. And anyone who works in the NMH, anyone who's been into the NMH who has to use the services, I think would say we just can't wait.
And so I understand that argument that perfection is the enemy of the good. And Rona, I know you're thinking, stop putting it off. We need to move. And I mean, I'm very familiar. I trod those corridors for years, so I'm very familiar with the hospital. I get it. But you hear the conversation that we're having. I know you're on the board of St. Vincent's. Yes, you're on the board of Vincent's, but you're the former master of Holles Street. The governance, it isn't just down to the land. There's also an overlap that there are people from St. Vincent's Hospital Group on the board of the National Maternity Hospital, the new one in its current projected format in terms of governance. And I suppose I don't doubt your bona fides or your bona fides for a moment, not even for a heartbeat. But what if you're wrong? And what if women are the ones who are shortchanged? And that's the fear.
So let's look at the facts, and I suppose let's look at the concerns. The facts, we have 3 standalone maternity hospitals in Dublin. It's unique. And they're not standalone because that's a good idea in delivering women's healthcare. They're standalone because they all began as charities, because no one else would provide that care. The state wasn't providing that care at the time. The state didn't exist when they were founded. I mean, Rotunda goes back to 1750, so they all began as charitable models. that was not a strategic approach to women's healthcare. We've just had a whole conversation about the kind of comorbidities that we are dealing with, the women who have cardiac disease, the women who have autoimmune disease, the women who have cancers, the women who have all kinds of intercurrent serious morbidities. The problems that arise at 3 o'clock in the morning when you're 3 litres down in the middle of an obstetric hemorrhage and you're on the site of Merrion Square, which is really lovely, pretty site, but that is no place to be when you are 3 litres down. And this is a regular occurrence for us. We are transferring patients in the middle of the night because if we don't transfer them, we think they'll die because there isn't an intensive care unit, there isn't a HDU. We are constantly transferring patients because you can't get a CT scan, because we need a surgical opinion, we need a medical opinion. It is not an appropriate place to deliver 21st century
No, I completely
healthcare.
believe you.
There is no department, despite, when I came as master, I was on a parallel track. We did an internal renovation to deal with the highest risks within the building to try and mitigate those, while having our eye on the appropriate solution, which is to move this hospital to a sophisticated adult tertiary hospital that provides the best care in the country. 40% of our doctors are employed between the two sites. We already work together as a virtual hospital. This is just giving effect to that working together. The building and the design of the building is really key as well. It is magnificent. It means that every woman who comes will have her own room, her own facilities. There'll be proper operating theatres that are to standard, proper labour rooms that are to standard, a proper neonatal care unit that allow women to room in with their babies and men and families to be with their babies. At the moment, we can't provide any of this. And not only is it not clinically, medically appropriate, it's actually really undignified.
Yeah.
Has anyone gone to Unit 3, we still call it Unit 3, and seen a 14-bed maternity ward in 2020? I get upset every day. I look at that ward.
I
and
totally
then
get that. That's the state of the art at Vincent's,
but it's also
that's
not
not
just
what people are worrying
not
about.
just state of the art. Women need care in a whole range of areas, and we can't give that care on site in Holles Street. So we are being told the whole time by certain quarters that the services available to women will be restricted. It is actually quite the opposite. The services available to women will be massively expanded. I've been a patient in Holles Street. I'm a doctor there. I've advocated for termination of pregnancy. I actually provide the service both under 12 weeks, both in the context of fetal medicine. I provide that service. I'm absolutely confident. Nobody has ever tried to impose ethos. From the very outset of Mulvey, it became very clear that there was no intention by any party to try and impose a Catholic ethos. That's well gone. It's totally inappropriate in providing modern healthcare. The nuns didn't try and impose ethos. Vincent's didn't try and impose ethos. The government didn't try and impose ethos. We certainly weren't trying to. So
is it
nobody.
Just a scaremongering thing in your
view? It is a scaremongering. In fact, there is nothing in any of the legal documents. There is nothing in any of the agreement. There is nothing that gives rise to the potential that this hospital will be governed. And for the very good reason that as a doctor, if you were to practice medicine where you couldn't give contraception, you can't. I mean, you would be apart from anything. We were governed by HSE, we're governed by our guidelines, we're governed by our standards. I mean, this is basic medicine to us. The idea that someone's going to turn around and say, because of Catholic teaching, you can't do that. This is just not a runner. There is absolutely no question of any religious ethos. There is no question of any Catholic ethos being imposed in this hospital. There is no mechanism by which this could happen. All of the legal agreements that are arising from the Mulvey Agreement must give effect to the Mulvey Agreement. And the Mulvey Agreement is explicit that there can be no religious control, no religious needs, and every single legal document that arises must give effect to that. And claims, and just to finish, I think it's really upsetting that women have been told that the care in this hospital will be delivered according to Catholic ethos. That is totally false, it's totally wrong, it's misinformation, it's been really distressing, and it has the potential to delay what is the most important healthcare infrastructure development for women in this century.
No, and I know that it is that important. We do want to take some questions from the floor, but before I do, I know the Minister wants to make one further point.
Thanks, Ciara. I think it's really important to say as well, in terms of the direction of travel for the HSE and for government in terms of termination of pregnancy services, we're expanding them. So as of last year, only 10 of the 19 maternity units provided services. It's now 11, and by the end of this year it'll be 14.
Okay.
Right, so we've gone from 10, we'll be at 14 of the 19 by the end of this year. And as you'll be aware, we've kicked off a very comprehensive review of the Act to make sure that where it isn't working properly and where the services need to be supported, that we're going to do that. So the entire direction of travel is to expand and invest in services.
Okay, look, thank you. We have time, don't we, Lisa, for some questions from the floor. There's a young woman with her hand up over there.
Just talking about there, Dr. Mahoney. So do you think, you mentioned there that there is a little bit of scaremongering that might delay the new hospital. I'm just conscious when the story came out, it was a time in Ireland when I think we were a year before repeal, it was a few months after Tuam. Do you think that the political and social climate and the intense distrust that people have with the Catholic Church maybe led to a little bit of misinformation? And Minister Donnelly, you were saying, you know, these options of maybe moving it to Connolly or whatever aren't a runner, because you'd be talking about a delay of a decade. But if you could do things again in the morning, would you pick St. Vincent's as the co-location site? And sorry, Dr. Mahoney, just while I have you, there were stories, a few stories in the press recently about concerns about the fact that the 3 masters of the Dublin Maternity Hospitals once again are all men. And I was just interested in your perspective, because I think everyone celebrated when you were appointed as the first woman, but I don't think anyone anticipated there'd be such a gap between the second woman and the third. So just those questions.
Thanks. Ciara, I might take a few questions before I go back to you. I'll try and get as many, if I can ask people to be as brief as possible, we'll try and get everyone in.
Yes, my name is Anne Conway. I just want to say to the Minister that I'm actually surprised that he's so worried about being sensitive to the nuns in relation, or to the in relation to a CPO of the land, you know, because that would mean state ownership, and that's what we want. We want state ownership. He should, I actually do honestly feel, and I would sort of say this to the Minister, the people of the country are actually more important. They're the people who elected the government, and they expect the government to deliver a service that they can have real trust in. And there's massive distrust amongst the population, and particularly women, that the new hospital will not be secular and will not be public. And I am one of the people who may be guilty of misinformation, but I don't believe why is there a lease, why is there a license, why has there been wrangling for 10 years over this and it's still not satisfactory? Clinically appropriate services doesn't mean anything. A doctor can decide what a clinically appropriate service is, not a woman. So I have no trust because it hasn't been transparent, and I think when things are transparent, then no lessons will ever need to be learned afterwards. And we've had a record in this country of lessons being learned, and we don't want that to happen in this new hospital. With 1 billion of public money, it could end up 2, it could end up 3, who knows? We've seen what happened with the Children's Hospital. So I would implore you to go back to the drawing board, go back and get a site that is actually in state ownership. That actually, I think, is an obligation to the people of this country and the electorate.
Thank you.
I'm going to change the tact. All of the panels today has been very much around the lack of knowledge and awareness around women's health. And, you know, from menopause, you know, endometriosis, menstrual health, everything. And Lisa, it's fabulous to hear you talk about cardiovascular disease. Every 2 hours we lose 1 woman in Ireland due to heart disease. There's not enough awareness about it. And it's brilliant to hear so much budget going towards women's health. The one area I would really like to just draw attention to is just making sure in the education and the knowledge and the awareness campaigns that, you know, we plan to do, and I do hope we see them happen, it's really important that Mary Bridget, the travelling community, who I do a lot of work with, aren't left out, as are, you know, we need to make sure all ethnic minority groups are taken into account, because I've seen firsthand when I work with the travelling community, education around menopause, particularly mental health, the suicide rates are much higher. It's an area we've really got to make sure that we take into account. Education is targeted for different levels and different groups within within society. So I think just as we're planning forward, and great change has been made over the last couple of years, and the Women's Task Force, which I've been privileged to be part of, you know, more of that. We just need to make sure that we keep the detail and we don't lose sight of all of the women involved in this journey. Thank you.
My name is Shompa. I'm very sorry, Catherine, I'm going to take it back to the National Maternity Hospital. I look around this room and I'm seeing a repeal jumper behind me, a lady with quite a strong opinion. Dee from Dee versus Ireland, Deirdre Conroy, was here previously. I can't see her now, but a lot of women who invested a lot of time and effort in the repeal campaign. And there's obviously a huge amount of reservation about ownership of the National Maternity Hospital. Minister Donnelly, something that you said about ownership of the hospital being subject to a lease of several hundred years, it's actually only 299. And I guess my question is, what kind of assurances are you able to give to us that on day one of operation of the new hospital, on day 299 of the new hospital, that these full range of health services will be provided? Everything can change. And we've all seen the impact of governance failures in cervical check. And you're talking about putting into place legal documentation to ensure that the full range of services are provided. Legal documents can be changed, they can be lost, amended. People change. We will all be dust in 299 years, but the next generation, the generation after, won't be. So what kind of assurances can you provide us now that on day one, and at every day into the future, the full range of medical services will be made available at the new maternity hospital?
I might take, we're gone way over time.
Yeah,
I just want to give a chance to the panellists to respond, because I think the main issue seems to be the maternity hospital. So I'll just go back to Ciara, because otherwise we won't get a chance to hear the response to the questions.
I think a lot of what has been asked on the floor has actually been dealt with in questioning that I put. But Rona, would you, I know the Minister is here, but you know, you're at the coalface of this.
Yeah, I mean, it's someone who also invested a lot of time in ensuring that the 8th Amendment was repealed to pave way for legislation, and someone who provides the service. This is good medicine. This is the care that is appropriate for women, as the provision of contraception, the provision of termination, the provision of IVF. All of these are part and parcel of our routine medical care that we give to women for the good reason that it is really important when we are advancing and giving good health care. That is not going to change when we move. The reason we are moving this hospital is actually to really invest in that, to expand the services that are available for women. Services like termination of pregnancy contraception are integral to the delivery of women's health care, and that is what we are about. What we want to do is deliver that health care in an appropriate environment where women have a dignified setting to access their care, where they have the whole range of backup facilities available, and where we are no longer speeding women through the streets of Dublin in order to the Constitution, the running of the women, and that's it. And anyone claiming that there is going to be an imposition of any religious ethos is wrong. It's not true. It was never true. From the outset, it was very clear that there would be services given free of any religious ethos, and as I've said, that is the agreement that we made, and every arrangement that follows that agreement must give effect to that, because that is how we deliver safe, better healthcare for women, and that's it. I think that in 300 years' time, I think we have to, I can't imagine how healthcare will be delivered, whether it be even delivered in hospitals in 300 years' time.
Today, we are creating legal instruments which have a 300-year tenure. Today. So if we're creating a tenure document that has an end date, that's not good enough for a public infrastructure project which is billions of dollars of funding. We need to be looking ahead for the entire duration of that infrastructure.
By any standard, by any standard, there's a long lease, but when you come to the end of a lease, it's not just a question that you can dismantle that lease. Any charitable, all of these are Irish companies run by company law, they're run by charity law. You cannot simply wind up and sell assets. Every single asset that is involved within a company that is regulated by charitable status by Irish company law, it must then go to another institution that provides the same services, that provides the same care. This is the whole point about companies with charitable status. You cannot buy them, sell them. There's no dividends, there's no profit, there's no selling. Nobody can come along and sell this hospital, and that is one of the great protections, actually,
in
of
fairness,
a long lease.
Rona, I think you've dealt, unfortunately we're just so far over time, and I appreciate your questions, and I actually very much understand the fear among women, because I think for a very long time in this country, women's rights and women's health was not taken seriously. So I understand where it's coming from, but unfortunately our panellists have to leave. We're very over time. Thank you all so much for coming. We really do appreciate it. And my sincere thanks to Minister for Health Stephen Donnelly, to Dr. Anne Nolan of the HSE, to Mary Bridget Collins from Pavy Point, to Dr. Rona Mahoney from the National Maternity Hospital, and from Mayo, emergency medicine consultant Dr. Lisa Cunningham. Thank you all so much for coming today.
I think it was really important that that conversation happened about the maternity hospital. Thanks to all of the team that ran the operation today, to all of the panellists, the moderators, and to everyone that attended and watched the conference through the live social media stream as well. I think you'll agree it's been a really powerful and inspiring day, and the first of many. And I think we have found our collective voice in the last couple of years. And by coming together, by creating awareness of these important issues, by demanding change, and by asking and speaking up for what we deserve and what we want and what we need in terms of women's healthcare, we will effect real change, and we'll do it now, not in 10 and 20 years' time. And that's the important message. So we will take what we've heard from today. All of the conversations are feeding in to the women's health policy that I've been developing within the party and with our female representatives for the last 6-7 months, and that'll be published next month, and you'll all be notified, and I look forward to using that policy document, working with Stephen and the rest of our government ministers to deliver that change in women's healthcare. So look, thanks everyone, and enjoy the rest of the day, and thanks again to our wonderful panel.